Assalamu alaikum. We are back after a few days with our Rheumatology 6th lecture. So, in the 5th lecture, we skipped two tables here, table number 26.5 and 26.6, box number, in fact. So, we'll start with these two boxes. So, first, while we try to study this box, first will have to keep a few things in mind. What are they? When we study calcium homeostasis, we'll have to remember that there are three hormones that regulate the normal level of calcium in our body. So what are the three hormones? These are, number one, we can say they are calcitriol or vitamin D. Calcitriol, that means vitamin D. Number two, we can say that it is parathyroid hormone. And number three is calcitonin. Okay, so these are the three hormones that regulate the normal level of calcium in our body. Okay, so what are their roles in calcium homeostasis? We'll start with parathyroid hormone because this is the most important one. So parathyroid hormone, what is its role? Parathyroid hormone increases the blood calcium level. So it causes increased calcium. But at the same time, it decreases the blood phosphate level. So decreased phosphate. Okay. This is the role of parathyroid hormone. It increases calcium level and decreases phosphate level. And let's come to the number two. Number two is vitamin D or calcitriol. So vitamin D increases both calcium phosphate, both calcium and phosphate. Okay. Vitamin D increases both calcium and phosphate. Now let's move to calcitonin. Let's move to calcitonin. So this is calcitonin. So its action or its effect on calcium and phosphate homeostasis is exactly opposite to calcitriol. Okay, so calcitriol increases both calcium and phosphate. So calcitonin decreases both calcium and phosphate. Both calcium and phosphate. Okay. Now let's come back to the box. So this box says typical biochemical features in various bone diseases. So we will not study the biochemical features and diseases according to this serial. We will start with osteoporosis, but we will not maintain this serial. Okay. For better memorization and better understanding, we will have to follow a different sequence of these diseases. So we'll start with osteoporosis. Osteoporosis is when we will find that someone's BMD score is minus 2.5 or below. And also in radiological appearance, we will see that the bone density is very much decreased in the X-ray. So then we can say that he is having osteoporosis. And regarding biochemical features, his calcium level will be normal, phosphate will be normal, alkaline phosphatase will be normal. Okay, just follow what I am saying. Okay, so don't get yourself startled seeing all these things, normal or increased, normal or increased. Just follow what I'm saying. Okay, so in osteoporosis, you will get a BMD score of minus 2.5 or below. You will get radiological osteopenia. and you will find that all the biochemical features are normal. Biochemical features means calcium phosphate and alkaline phosphatase levels are normal. So after this osteoporosis, we will study osteomalacia. What is osteomalacia? So we all know that deficiency of vitamin D in adults is called osteomalacia, and deficiency of vitamin D in children is called rickets. So in osteomalacia, that means in vitamin D deficiency in adults, what will be the features? So we have earlier studied that the normal effect of vitamin D in calcium and phosphate homeostasis it increases the level of both calcium and phosphate. So when you will have vitamin D deficiency, so you will have a decreased level of both calcium and phosphate. Okay, so the calcium level is decreased, the phosphate level is decreased. Okay, the alkaline phosphatase level will increase as a response to this decreased calcium and phosphate. The parathyroid hormone levels will increase. That is also a compensatory response to the diminished calcium level. Vitamin D deficiency. It is a disease of vitamin D deficiency. So the level of 25 hydroxy vitamin D is decreased. Okay. So I think and I hope that we are clear about this disease, vitamin D deficient osteomalacia. Here the calcium level is decreased, the phosphate level is decreased, vitamin D level is obviously decreased as a compensatory response. Parathyroid hormone level is decreased and alkaline phosphatase level is also, the parathyroid hormone is increased as a compensatory response and alkaline phosphatase level is also increased. So we have learned osteomalacia, biochemical features. Now, similar disease in children is rickets. Vitamin D deficiency in children is called rickets. So in rickets, there will be diminished 25 hydroxy vitamin D level. So as it is a hypophosphatemic rickets, so in rickets, we like osteomalacia, we would expect that the calcium level and phosphate level, both of their levels will decrease, but it is a different type. It is just hypophosphatemic rickets. So here the calcium level still remains normal. Only the phosphate level is decreased and vitamin D level is obviously decreased. Parathyroid hormone level is increased and alkaline phosphatase level is increased. So quite similar with osteomalacia, just the difference is that there is only hypophosphatemia, not hypocalcemia here. The calcium level here remains normal. Okay, this is rickets. Now, we'll come to now hyperparathyroidism. Hyperparathyroidism is three types: primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. We will learn more in details about different types of hyperparathyroidism in renal system and also in endocrinology. Okay, so we will not go into that details. So in primary hyperparathyroidism, primary means the disease is in the parathyroid gland. So there will be parathyroid hyperplasia and there will be excessive secretion of parathyroid hormone. So in primary hyperparathyroidism, the parathyroid hormone level is increased. The parathyroid hormone level is increased. So as we studied earlier that parathyroid hormone level normally causes an increased calcium level and decreased phosphate level. So the corresponding biochemical change will be increased calcium and decreased phosphate. Alkaline phosphatase level will be increased, and so as calcium level is very much increased as a compensatory response or as a reaction, the vitamin D level will be decreased so that the calcium level does not increase further. Okay. So this is the primary hyperparathyroidism. Now we'll come to renal osteodystrophy. So first we have to know that renal osteodystrophy is also known as secondary hyperparathyroidism. Okay, this is also known as secondary hyperparathyroidism. Secondary hyperparathyroidism. Okay, this is secondary hyperparathyroidism. So what do we mean by secondary hyperparathyroidism. That means the primary disease is not in the parathyroid gland. The primary disease is elsewhere. And the parathyroid gland is responding by hyperfunctioning because of the primary disease. Okay. So in renal osteodystrophy or secondary hyperparathyroidism, the primary disease is CKD. The primary disease is CKD, chronic kidney disease. Okay, this is the primary disease. So this is the primary disease in CKD, in secondary hyperparathyroidism. Okay. So in CKD, what happens? The kidneys have very poor functioning, as kidney is the site where vitamin D is activated finally. The final activated form of vitamin D is produced in the kidneys. So when the kidney has chronic failure, that means the chronic kidney disease, the levels of activated vitamin D will decrease. If vitamin D level decreases, blood calcium level will also decrease. So as blood calcium level decreases, as a compensatory response, the parathyroid hormone level will increase. This is called secondary hyperparathyroidism. And this parathyroid hormone increased level will cause increased will cause the compensatory response to the parathyroid hormone. So let's come again. In secondary hyperparathyroidism, the levels of vitamin D level will decrease. The level of vitamin D decrease. Calcium level decreases because the kidney disease. Phosphate level increases because the kidney fails to excrete the phosphate. So in secondary hyperparathyroidism, there is kidney failure. So there is calcium, low calcium level, high phosphate level. The activated vitamin D level is decreased, parathyroid hormone level is increased, and alkaline phosphatase level is increased. So this is the secondary hyperparathyroidism. So the only disease that is left now is Paget's disease. Paget's disease. In Paget's disease, everything is normal just except the alkaline phosphatase level. Calcium level is normal, phosphate level is normal, just the alkaline phosphatase level is increased. So this is the biochemical finding of Paget's disease. I hope this box is very much clear now to you all, because I have given a lot of time in this box and a lot of emphasis in the important diseases. Now let's move on to the next box. Causes of an elevated serum creatinine phosphokinase or elevated CPK, creatinine phosphokinase levels. So the diseases are inflammatory myositis, so inflammation of the muscle, with or without vasculitis, in muscular dystrophy also, in motor neuron disease. Alcohols may cause an increase in CPK. Some drugs, especially the statin, that means the typical lipid-lowering drugs, the atorvastatin, rosuvastatin, etc. These drugs cause an increase in creatinine phosphokinase level. In MI, the CPK level increases. In myocardial infarction, the CPK level increases. In any trauma, in strenuous exercise, that means the severe exercise, prolonged immobilization after a fall also causes an increase in CPK. Hypothyroidism causes an increase in CPK. Okay. Metabolic myopathy, increased CPK. Viral myositis, increased CPK. So when you study the causes of increased creatinine phosphokinase, you will have to first keep in mind that any disease in the muscle may cause an increase in CPK level. Okay. Okay. These two boxes are complete. Now we will move on to our next topic, tissue biopsy. So regarding tissue biopsy, temporal artery biopsy is an investigation which is very helpful in diagnosing the temporal arteritis or giant cell arteritis. This is a disease of blood vessel. We will study this disease in the vasculitis section. Okay. So let's come back. So let's move back further. Biopsies of affected tissues. Biopsies of affected tissues such as skin, lung, nasopharynx, gut, kidney, and muscle are of value in confirming and diagnosis of systemic vasculitis. Okay, so systemic vasculitis here, we will biopsy different tissues like skin, like lung, nasopharynx, the GIT, the kidneys, muscle. They are of value in confirming the diagnosis of systemic vasculitis. Okay. Muscle biopsy is important in the investigation of myopathy and inflammatory myositis, usually taken from quadriceps or deltoid muscle. This is very important for the single best answers. So this information is important for your MRCP exam and also your FCPS exam. So which muscles are the site from where muscle biopsy is taken? The deltoid muscle and the quadriceps muscle. Deltoid muscle in the upper limb, quadriceps muscle in the lower limb. Now, bone biopsy. Bone biopsy is taken from which area? The iliac crest. This is also very important for your single best answer. So bone biopsy is taken from iliac crest. Bone biopsy is taken from iliac crest. Okay. Electromyography. Electromyography is the investigation of myopathy and inflammatory myositis. Okay. So finally, we will start the presenting problems in musculoskeletal diseases. Okay. First, we will study monoarthritis. Mono means one, single. So arthritis means inflammation of a joint. So monoarthritis means inflammation of a single joint. So this refers to pain and swelling affecting a single joint. The most common causes are crystal arthritis, sepsis, reactive arthritis, and oligoarticular JIA, juvenile idiopathic arthritis. So as causes of monoarthritis, we will have to remember that crystal arthritis is number one, number two is septic arthritis, and number three is reactive arthritis. Okay. A very rapid onset. That means the onset of 6 to 12 hours. So within 6 to 12 hours of pain onset, if the joint is very quickly swollen, becomes red, very tender. So this is a very rapid onset. So this is suggestive of either gout or acute calcium pyrophosphate arthritis. That means the pseudo gout, which is also known as pseudo gout. So gout classically affects younger men and particularly targets the first metatarsophalangeal joint. So this is very important. In the clinical vignettes or scenario, we will find that the patient is a young male, is having severe pain and swelling in his first metatarsophalangeal joint. So this is very typical scenario for gout. Whereas the CPPA, calcium pyrophosphate arthritis, tends to affect older women. So in older women, the pseudo-gout is more likely than gout. The presentation will be quite similar. Just because of the age and gender, we will have to arrange our differential diagnosis according to that. Okay. So reactive arthritis can also develop acutely and may be preceded by a diarrheal illness or genital infection. So this is very important for studying reactive arthritis. Reactive, the word reactive. I am putting some emphasis on this word, reactive. So the reactive means reaction. Reaction to what? Reaction to a primary event. So the reaction is what? The reaction is arthritis. That means joint inflammation. So what is the event for which arthritis is occurring? The event may be diarrhea. That means the GIT is involved here. And also the event may be a genital infection. So the reactive arthritis may be enteric acquired or it may be sexually acquired. Okay. So the septic arthritis develops more slowly. So the reactive arthritis develops quickly and gout and pseudo-gout develop also acutely. The septic arthritis develops more slowly than these two kind of diseases and continues to progress until treated. Okay. Hemarthrosis, that means bleeding inside the joint, usually follows an injury and may be associated with a large effusion. If there is hemarthrosis, there is large joint effusion. That means large swelling of the joint. Okay. So this is a box. This is regarding the causes of monoarthritis. So number 1 is gout or crystal arthritis. Number 2 is pseudo gout. Number 3 is trauma. And number 4 is hemarthrosis. Number 5 is reactive arthritis. Okay. And also septic arthritis is another cause. So what it is written in the star marked section, in children, both leukemia and osteomyelitis may present with monoarthritis. Okay. Osteoarthritis can present with pain affecting a single joint, but the onset is gradual. Okay. Typically, the onset is gradual. Investigation. So the first line, very important to remember. Aspiration of the affected joint is mandatory in patients with sudden onset of a hot swollen joint. So if you find a sudden onset of a hot swollen joint, aspiration of the joint fluid is very much mandatory. Okay, we'll have to keep that in mind. The fluid should be sent for culture and gram stain to seek the presence of organisms and should be checked by polarized light microscopy for crystals. Okay. Blood culture should also be taken in patients suspected of having septic arthritis. CRP and ESR should be measured. Serial measurements can be useful in assessing the response to treatment. Very important. So CRP and ESR, we will measure them serially, initially also, and we will also follow the progress of the disease with these two values. If the CRP and ESR levels are decreasing, that means we are having a good response to our treatment. Okay. Serum uric acid measurements are of limited value since urate is a negative acute phase reactant and values can fall to within the normal range in acute gout. So, in acute gout, serum uric acid measurement is not very much helpful, okay? Because it is a negative acute phase reactant. That means in any acute inflammatory phase, the level of serum uric acid level decreases. So we will think that it is not a case of gout because the uric acid level is decreased or normal. But actually the case is in any acute inflammation, serum uric acid level may be decreased because it is a negative acute phase reactant. Okay. So if the investigation suggests calcium pyrophosphate arthritis, an elevated serum calcium may suggest underlying primary hyperparathyroidism. Okay. We know that. Regarding the management of acute monoarthritis, if there is any suspicion of septic arthritis, we will have to give IV antibiotics. Intravenous antibiotics should be given promptly, pending the results of culture. So even before the result of culture become available, we will have to start empirical antibiotics, and that is also IV antibiotics, not oral, for septic arthritis. Patients with suspected crystal-induced arthritis or reactive arthritis may be given intra-articular glucocorticoid injections. So gout patients and also pseudo-gout patients and also reactive arthritis patients may be given intra-articular steroid injections to help the pain and swelling, but only if gram stain is negative and synovial fluid culture has been negative for 48 hours. So before giving the intra-articular injection to a patient of acute gout, acute pseudo-gout, or acute reactive arthritis, that means reactive arthritis, we'll have to first ensure that we have done joint fluid study, the gram stain is negative in the joint fluid, and also the culture report is negative at least for 48 hours. Okay. So these are all for today. We will start with polyarthritis in the next class. Till then, bye for now. Assalamu alaikum.